you today about what the science of COVID is saying regarding not about how deadly it actually is, and also how deadly the lockdowns that we have used to control COVID is. Everything I'm going to be telling you is from the peer-reviewed literature. So it's actual science, although very often people haven't heard very much about it. And so in doing so, I'm going to tell you a little bit about the story of how I got to this, and then I'll end with the policy proposal, the Great Barrington Declaration, for a radically different policy for controlling COVID, while still addressing the harms of the lockdown at the same time. Okay, so Supervisor Hewitt told you about the antibody studies. Let me describe what the scientific problem is. It turns out that when you think about who gets COVID, where do you go look? You go look on the media sites, or you go look on the Johns Hopkins site, and it gives you the number of cases of COVID that have been diagnosed to date. Well, in the early days of COVID, March, April, we weren't doing a ton of testing. We were reserving the testing for people who actually got sick. And that actually makes good sense that you would do that. We've since then ramped up the testing. But it turns out that COVID doesn't just cause the very deadly viral pneumonia that you see on TV. And in fact, it has a very wide range of clinical presentations, ranging from no symptoms at all to mild cold-like symptoms, all the way to the deadly viral pneumonia, all the way in between. And the people who have the mild symptoms often don't show up in the case counts. This actually happened once before, in my awareness, during the 2009 H1N1 epidemic. The early estimates of the number of cases turned out to be a very large underestimate of the actual number of infections. Now, you might think of this as bad news, but in fact, if you think about it, if there are a lot of people who get the disease and recover, we don't even really know about them, that's actually good news, as long as it induces immunity. And in fact, it does, and I'll tell you that story also in just a bit. So what you have before us is a disease that I'm going to tell you the evidence, but is much more common than we sort of realized at the beginning, and much less deadly than we realized at the beginning. So let's spin back to March. You remember March, you saw the headlines of last year. The World Health Organization put out a number that said that the mortality rate from COVID was 3.4%. 3 out of 100 people. 3 out of 100 people. Now that number is absolutely shocking, because if it's true, it is a deadly disease that requires an enormous, maybe even the lockdowns. I mean, I'm not sure, but that really would require something like that. Well, if there are many more people who are infected than the cases, that number is going to be off by an order of magnitude. In fact, that's what happened with H1N1. The early reports were 2, 4, 7, sometimes actually in Argentina, 14% in 2009, the H1N1 flu. And then what happened was studies started coming in saying that it was much more widespread, and we learned that in fact H1N1 kills about 0.02%, not 2 out of 100, not 2 out of 1,000, 2 out of 10,000. It's a much less deadly thing than we thought. In the early days of the epidemic, I had that same hypothesis. I'd been paying attention during H1N1. I thought, okay, maybe that's true for COVID as well. So what I did is with my colleagues and former students is we organized seroprevalence studies, just like Supervisor Hewitt said. So seroprevalence means let's check for people's with antibodies to COVID in the bloodstream. If you have an antibody to COVID, that means you had the infection, right? That means that you were previously infected. The thing about COVID is that, think about the virus that causes COVID, when you recover from it, it's more like the cold than it is like HIV or chickenpox. It doesn't stay in your body, it leaves your body, it's gone, your body removes it. And so you can't just look to see if the virus actively is in you, you have to look to see if you have evidence of the previous infection. Well, the antibodies provide that evidence. So we ran these studies in Santa Clara County, in Los Angeles County, and actually now there are now 100-some studies like that have been published about this around the world. They all tell the same story. There are many, many times more infected people than cases. And the death rate from COVID, well, let me explain what that is, because it's really important. It's unlike the flu, actually, in one sense. For people who are over 70, it's more deadly than the flu. Just to give you a sense of the survival rate from these seroprevalence studies around the world, 95% of people who are over 70 survive COVID infection. 95%. 5% mortality, it's a very high mortality rate. If you're under 70, the survival rate from COVID is 99.95%. 99.95%. And in fact, for children, it is less deadly than the flu. Right? We send our kids to school despite the risk of the flu, but fewer kids have died this year, or this past year in 2020, from COVID than died from the flu the previous season. By a long shot, actually. For kids, this is not a particularly deadly disease. And in fact, what the argument I'm going to make is that for kids, and actually for much of the population, the lockdowns are worse than COVID. The lockdowns are deadlier than COVID. Okay, so that's the first thing. So now we know what the risk of COVID is. There's a 1,000-fold difference between the oldest and the youngest in the risk of mortality from COVID. There's some other risk factors as well, if you're diabetic, for instance, but those risk factors are not nearly as important as age. Just to give you a sense of that, if you're 65 years old and you have diabetes, you have roughly the same risk as someone who's 70 without diabetes. Right? So diabetes adds 5 years of risk. Age is the #1 risk factor for a bad outcome from COVID. And it's really the oldest. And you can see this in the mortality statistics. About 80% of people that have died from COVID or have been assigned COVID as a cause of death are people who are over the age of 65. 80%. Okay, now let's go to the other side of the equation. This is the side of the equation that the public health authorities, for completely inexplicable reasons, have ignored. How deadly are the lockdowns? We've been told that the only way to control COVID spread is to close our schools, to close our businesses, to close our churches, to close all normal human activity. And the argument is that, well, life is more important than those activities, and so we'll just suppress them for a while until COVID is done. Well, let's think about that. What are the consequences? I'm going to leave aside economics because if I talk about economics, I'll end up in a place where people will accuse me of being callous. So I'm just going to not talk about economics. I just want to talk about the harms from the lockdowns themselves. So there was a study just published last month in the Journal of Medical Association that estimated how many life years our children have lost as a consequence of the lockdowns. The study just looked in the lockdowns, the closure of schools in March, April, and June of this past year, just 3 months. Now, this maybe doesn't surprise anyone. If you miss school, it's not just that you've missed that education. It actually has lifelong consequences. Lifelong consequences. People who miss school for a short period of time end up in their life poorer and less healthy, and actually less long-lived. Poorer, less healthy, less long-lived. We, by closing schools just for those 3 months, robbed our children of 5.5 million life years in expectation. And this is a published study in the Journal of American Medical Association. 5.5 million life years in expectation. We closed our hospitals for patients other than COVID all through the spring and the summer with the idea that the hospitals are going to get overrun. Well, what did that do? Many patients who had heart attacks didn't come in to get care. Many patients avoided getting needed chemotherapy. People skipped screening for cancer. There's going to be a spike in late-stage breast cancer patients, women with breast cancer this year, because of which should have been caught last year. We decided that the only health issue that mattered was infection control, and we decided to ignore all the other afflictions that we know are deadly with the idea of infection control. Right? So we're going to see worse health outcomes, and you don't just look at the last year's statistics, although they're bad enough. This is something that will play out over a very long period of time, because these are what we skipped are diseases that are manageable if you pay close attention to them, but not manageable if you skip the basic treatments. Diabetes, all these basic things that we knew how to do, we decided not to do last year because of fear of COVID. That is if we think just domestically. Well, what about internationally? Okay, now I'm going to turn a little to the economics. The harm from COVID was that internationally, I mean, there's a lot of harms just along the medical lines I mentioned, but I want to just focus on poor countries. In poor countries around the world, there are many, many people who live on a very small number of dollars a day, $2, $3, $4 a day. When the economic harm happens, when you're hit by a GDP hit of 10%, it doesn't fall randomly. It tends to fall worst on the poorest. That's actually true in the United States as well, by the way. The UN estimated in April that 130 million additional people will starve as a consequence around the world as a consequence of the economic harm from the lockdowns. 130 million people. That belongs in the equation when we're thinking about our policy, right? You can't just ignore people starving to death as a consequence of the policies in order to protect yourself. You have to, I mean, we're a moral people. We should consider that as well in our policy making. Okay, so the health harms from the lockdowns are absolutely devastating and enormous. Let me give you one other psychological data point. In June of this past year, 1 in 4 young adults seriously considered suicide in the United States. 1 in 4 18 to 24-year-olds, according to a CDC survey, seriously considered suicide. During the 2008 Great Recession, we had a sharp rise in suicidality. We had a sharp rise in opioid use. We had we called it the Great Recession, and we called it deaths of despair. Calling that great is going to seem quaint from what's coming and what we've already experienced. And the lockdowns, they didn't actually protect people from COVID. Think about the lockdowns. We have essentially now 2 castes of society. The caste of society that can sit at home, work remotely, not miss a paycheck at all. And you have a caste of society who's deemed essential in sort of an Orwellian term and asked instead to, you're 64 years old, you're diabetic, you're actually at pretty high risk of mortality if you should get COVID, but if you're a Costco clerk, well, you still got to go work. We provided no accommodation whatsoever through these lockdowns to protect people we know to be vulnerable. The lockdowns are a luxury of the rich and have harmed the poor in every single country on the face of the earth. Every single poor person, every single poor nation on the face of the earth has been devastated by the consequences of this lockdown. It's only the rich that they seek to protect. Okay, so let's put these 2 facts together. We have a disease that is deadly for the old, 95% survival, deadly for people with certain chronic conditions where we know what those are. We have a disease that is much less deadly for the young. The lockdowns, on the other hand, for the young have been devastating. Young meaning if you're under 60, you're young as far as I'm concerned. 65? I don't know. That maybe I shouldn't hazard a guess. I'm getting up there myself. 60, right? So if you're low risk of mortality from COVID, I consider you young. And for you, the lockdowns have been way more deadly than COVID. So what's the right, compassionate, sensible, moral policy? One that doesn't foment inequality, that respects the scientific facts about who's most at risk from COVID. Well, it's very simple. Let's protect our older populations. Let's not send people infected with COVID back to nursing homes. Let's devote every resource we can to protect people in nursing homes, because that's where 40% of COVID deaths have happened. For people living in multi-generational homes, let's provide alternate living arrangements if someone in the house happens to be exposed. For people who are in the workforce that happen to be high risk, let's use our disability accommodation laws so that you can, for instance, a teacher that's 63 with high risk, that teacher maybe can teach remotely, whereas let's have the younger teachers, let's teach our 6-year-olds to read again, right? So we need to be clever about this, and we could be clever, we could be creative about this. But instead what has happened is we said, we're just going to adopt a lockdown. We're only going to adopt a single thing that actually doesn't protect a lot of people, exposes many people, and then causes by itself enormous collateral harm. So let's protect the vulnerable. That's the first thing. And now with the vaccine, we have a fantastic tool to do that, a perfect tool. We can use the vaccine by preferentially giving it to people who are older. And I've seen like stories of, in fact, pictures all over the place of young people getting the vaccine. And if you look at the statistics, in California, only to date, I think less than 2% of the vaccine doses have gone to people over the age of 70, which is an amazing mistake. On the other hand, for the young, the lockdowns are worse than COVID. Psychologically damaging, economically damaging, medically damaging, and will lead to long-term harm to the lives of people who are much less risk from COVID. But for those folks, let us resume normal life. Let us get back to what we know produces good outcomes in society. Let's work on our schools. Let's open our schools. Let's open our churches. Let's open our businesses. I'm not saying don't take precautions, right? COVID is still, you don't want to pass it on to people who are older, and not everybody is vaccinated as yet. But we have to take account of the harms that we're doing to society. Just absolutely devastating harms that are in many ways irreparable. So that is the sum and substance of the Great Barrington Declaration. In October, I along with Professor Sunetra Gupta at Oxford and Professor Martin Kulldorff, came together in a little town in Massachusetts called Great Barrington, and we realized Sunetra Gupta is a theoretical epidemiologist. He's responsible for figuring out what the right flu vaccine should look like every year. Professor Martin Kulldorff is a professor who his entire career has been focused on tracking vaccine safety for the FDA. We're all scientists here, and we looked at the public health response, and it is completely out of proportion. We have, in many ways, damaged our society beyond all measure. I've come to think of the lockdowns as, you know, when we dropped the nuclear bomb at the end of World War II. That was, for physics, the end of the age of innocence. Well, the lockdowns are public health's nuclear bomb. And it's fallen on every single poor person, as I said, on the face of the earth. So what should we do? Open society again. Take precautions as necessary. Spend every resource imaginable. Lord knows we've already spent so much to protect the vulnerable, the old. Use the vaccine preferentially. If we actually could have enough doses, we have enough doses of the vaccine to give every single older person in the country by the middle of February the vaccine. And at that point, what's the argument? Because that's where all the death is. We prevent the death with the vaccine, and we open up the rest of society. So that's all I have to say, and I look forward to the other panelists, but thank you very much.